Good afternoon. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Long-Term Care Emergency Preparedness Educational Series, Should I Stay or Should I Go? My name is Christine Bingman, and I will be your moderator for this program. Now I'd like to introduce our speaker for the webinar. Joanne Atkins is a registered nurse and senior infection preventionist for the Patient Safety Authority. Ms. Atkins is board certified in infection control and epidemiology and is a fellow of the Association for Professionals in Infection Control and Epidemiology. Ms. Atkins is the 2019 recipient of APIC's Heroes of Infection Prevention Award for Education. She is a member of the Association for Professionals in Infection Control and Prevention and has served on the Member Services Committee. Also served on the Sigma Theta Tau International Nursing Honor Society and the Pennsylvania Association Directors of Nursing Administration Long-Term Care. Joanne, I will now turn the program over to you.
Thank you, Christine. Welcome everyone to the 6th installment in the Long-Term Care Emergency Preparedness webinar series. Today's webinar, Should I Stay or Should I Go?, is going to discuss shelter in place and evacuation. There are many times during a disaster or an emergency when healthcare facilities may need to shelter in place, relocate their residents, or evacuate the facility completely. When faced with the difficult decision of having to evacuate or stay in long-term care, many factors need to be considered. Sheltering in place is the preferred option, yet implementing this option calls for a complex chain of decisions and actions. While evacuation is typically not preferred, there may be times when this option is safest for the residents and staff. Due to the varied abilities of nursing home residents, evacuation can be a daunting task without appropriate consideration and planning ahead of time. So our objectives for today are to review the CMS Emergency Preparedness regulatory requirements for evacuation of your residents, discuss the 3 elements of an evacuation plan, and describe the contents of a shelter-in-place plan. So CMS Requirement 42, 483.73 is the Emergency Preparedness Regulation. And long-term care facilities must comply with all applicable federal, state, and local emergency preparedness requirements. And that includes developing and maintaining an emergency preparedness program that meets the requirements. Your plan when it comes to sheltering in place or evacuation, you need to think about what are the provisions for subsistence needs for both your residents and your staff that are caring for them. Your plan must have a system in place to track location of on-duty staff and your residents. The plan must have a procedure in place for safe evacuation from the facility and a means for those people who remain in the facility to shelter in place. You also have to provide for them also. Your plan must have a system for medical documentation, and it must include the use of volunteers or other emergency staffing strategies to make sure you can continue to provide care. It also requires arrangements with other long-term care facilities and providers in case you would have to evacuate. Where would you evacuate to? And then also the plan must include the role of the facility in the care and treatment of your residents at this alternate care site. While evacuation is typically not preferred, there may be times when this option is the safest for residents and staff. As I said before, because of the varied abilities of nursing home residents, it is a very daunting task. Prior planning regarding how residents will be transported, who will provide the transportation, what specialty types of vehicles will be needed, and where these vehicles and transportation staff will come from, all must be prearranged in order to maximize the safety of residents and staff. Evacuation planning also includes determining what supplies, food, water, medication, and other physical items will be needed in order to maintain safety. Predetermined locations should be identified where residents can be taken that will adequately meet their needs. Identifying these predetermined locations and having discussions ahead of time will ensure a smooth transition should that occur. Additionally, it is important to have evacuation agreements with more than one facility. Traditionally, facilities often closest to your nursing home would be someone to partner with, but it's important to remember that facility may also be in the midst of the same emergency you are, if it were a flood, for example. So a second facility some distance away is prudent in the event that that close facility may be affected and unable to handle your transfer request. The staffing plan should include how the relocated residents will be cared for at the sheltering facility, as well as the number and type of staff that's needed at the evacuating facility to help move your residents. This staffing plan should include a description of how care will be provided to the relocated residents, an identification of the number and type of staff needed to evacuate your facility and also to accompany your residents to the sheltering location, and a plan for relocating facility staff. It is also important to have a contingency plan if your facility staff cannot make it to the shelter due to their own family's needs. Transportation planning is also very important. The transportation plan should describe how residents will be transported to the shelter. It should include any contracts or memorandums of agreement with transportation companies, ambulance services, or other transportation modalities. The actual transportation plan should list the number and types of vehicles required, how the vehicles will be obtained, who will provide the drivers of those vehicles, medical support to be provided for the patient or resident during transport. It is important to think about the following support needs. You have residents who are independent in ambulation, residents who require assistance with ambulation, residents who are non-ambulatory, residents with cognitive impairments, and residents with equipment or prosthetics. That equipment and prosthetics need to accompany the residents and should be securely stored in that designated mode of transportation that resident is being transported in. Another part of your transportation planning is an estimation of the time it will take your facility staff to prepare your residents for transport, an estimation of the time for the facility to prepare for evacuation, an estimation of time for the patients or residents to reach that sheltering facility, a detailed route to be taken to that sheltering facility if possible, and a description of what items are sent with the residents, such as their medical record, which would contain medications that the resident is taking, the dosage, the frequency of the medication, the route of administration, any special diets or special care needs. Another item to be sent with your residents would be a 3-day supply of medication if possible, and any specialty medical supplies. And then other items to be considered would be clothing or incontinence diapers, that sort of thing. Medical records should be provided to the receiving facility and remain with that receiving facility until the resident is transferred back. And records should be maintained of which residents are transported to which facilities if you would have to evacuate to more than one. And this slide just goes on to reiterate what I just discussed. Evacuation destination information. The plan should describe where the residents will be transported. The receiving facility should be appropriate for the level of care required for those residents. Your transportation and evacuation plan should include as an attachment any contract, memorandum of agreement, or transfer agreement the facility has with that receiving facility. Your evacuation destination plan should also include what your sleeping plan would be. The feeding plan, how are meals going to be provided to your residents? The medication plan, and where are the medications coming from, who is procuring them, and who will be administering them? Accommodations for your staff that is relocated to care for your residents. And also, it's important to know the number of relocated residents that facility can accommodate. The staffing plan should include how the relocated residents will be cared for at the sheltering facility, as well as the number and type of staff that is needed at your facility to help evacuate them. And again, I'm going to reiterate, it's very important to have a contingency staffing plan, as you may have staff who cannot make it to the shelter depending on what the emergency is that is occurring. So it is preferred to shelter in place and not transport your residents. So in certain situations, such as a chemical incident, your facility may be better off to stay in shelter in place. So there has to be a plan for sheltering in place. In an emergency, your facility could be without telephone or communications, electric power, or water and sewer service for several days. The facility must be able to exist on its own for 72 hours without outside assistance. The plan should include provisions for resident care and monitoring of medical conditions, facility safety and security, food, water, medication, a way to have contact with first responders, your fire, police, EMS, etc., public health departments, any transportation requirements, staffing for your residents when your facility is sheltering in place, how you will maintain lighting and temperature control, waste disposal, and medical supplies. The sheltering in place plan is not to be specific to the event requiring sheltering. Instead, the plan should contain the following. The plan should describe how 3 days of non-perishable meals are kept on hand for residents and staff, including any special dietary requirements. Should describe how 72 hours of potable water is stored and available to residents and staff. Should identify 72 hours of necessary medications that are stored at your facility and how necessary temperature control and security requirements will be met. It should also identify staff that will care for your residents during the event and any transportation needs of that staff, and how you as the facility will meet that need to get staff in. Think about a blizzard or severe weather event where there may be difficulty for people to get through the roads. How are you as a facility going to help accommodate transportation for your staff? It should identify the plan that's in place for an alternate source of power, such as an on-site generator, and describe how 72 hours of fuel will be maintained and stored. Alternate power source plans provide for necessary testing also of that generator. There should also be in the plan a description of how you will dispose of or store waste and biological matter and biological waste until normal removal is restored. It should describe your emergency communication plan, such as cell phones, radios, laptop computers, ham radio if necessary. It should also note that there was consideration given to the needs of residents, such as dialysis residents, and that adequate consideration was given for residents on oxygen and how you would continue to provide that service, or for residents that use durable medical equipment such as masks, colostomy supplies, etc. There are potential triggers that prompt protective actions. And this slide lists the most common factors that are seen nationwide that prompt protective action: fire, flooding, severe weather, chemical leaks, or utility systems failures. But these are by no means the only one. It is always important when you do your all hazard risk assessment that we've discussed in previous webinars that you look at your institution or regionally appropriate threats to make sure that you are addressing those. So I wanted to just go through a couple definitions to make sure everybody is talking about the same thing. When we talk about shelter in place, these are residents that are sheltered on the same unit that they have been residing on in your facility. You may need minimal movement, like from one room to another, to get away from a specific hazard, but they're staying on their same unit. When we talk relocation, your residents are moved to other units within your facility. It could be a horizontal move from one hallway to the next, or it could be a vertical move from floor to floor, but they remain within your facility overall. When we speak evacuation, then your residents are moved to another healthcare facility for continued care due to unsafe conditions. If it is a partial evacuation, it's just a subset of patients. It could be one unit, one hallway, or maybe we're moving just our dialysis residents because of unsafe water during flooding. Or it could be all patients, which is a complete evacuation. And again, I'm going to remind you, the term evacuation is for movement outside of your facility or campus. Relocation is for movement within the physical space of your facility. There are two types of actions. We have no notice or emergency evacuation, which is an immediate evacuation. For example, a fire happens within your facility, so you need immediate evacuation depending on the scope of fire. An urgent evacuation is an evacuation that must occur within a matter of hours. For example, the river is rising in central Pennsylvania and there is an anticipation of flooding. You know that your facility in that flood zone has a matter of hours before you will have to evacuate as the flooding is starting to occur. We activate our incident command system, but there are always certain decisions that must be made by the personnel within your facility. A threat recognized by unit staff that requires immediate action to shelter or relocate is always within the authority of that unit's staff, and that's important. I know when speaking with some of you, your emergency preparedness plans, it was administration that was the incident commander and made those determinations, but I know both Jason, Pam, and myself have emphasized this many times through the course of this series. The person that is within the facility that is seeing what is actually happening has that determination. That is within their scope to make that call. So here's your factors that influence action. the time to the event or proximity, the duration of the event, the impact of that event or the gravity of it. Is it a potential life-threatening event? And then what are the impact of actions taken? None of these factors is all controlling. It's a balance of all of these. One thing you have to think about is how you're going to evacuate your unit. Will you be taking residents down stairwells? Is it safe depending on what the emergency is to evacuate by your elevators? It is critical that unit staff understand what their responsibility is in response to a given threat and where those designated relocation areas are within your facility. Horizontal movement is much faster and less risky moving across from one unit to the next than vertical movement going up and down in floors, especially if the situation does not allow for elevator use. In urgent situations, gathering records and belongings is critical to assuring ongoing safe medical care. But the more immediate the risk, less time should be spent on that activity. So here are your unit-based actions that staff need to be aware of and prepared for. The charge nurse or your unit leader has the authority to initiate shelter and relocation actions, as would any staff that sees an unsafe situation within your facility. That unit leader should activate the incident command system and notifications appropriate to the event that has occurred. Each unit should have a clearly identified pack with vest, room clear labels, tracking tags, and other supplies. And following any unit-based actions and based on the event that occurred, the unit leader may begin triaging and preparing patients for movement to a staging area for evacuation while awaiting instructions from Incident Command. So here are the Incident Command decisions. Situational awareness. What is the impact of this event? What is the onset or duration of this event? What's the timeline? And what facility resources are available or what have been effective? Your situational awareness and your command decision may require ongoing analysis, such as the river is rising and we are anticipating flooding. And it may be impacted by outside factors. Part of your situational awareness is, did this event impact my ability to get supplies in for my residents? Did it impact the amount of potable water we have available? And then the command decision comes down to your action analysis. Is there a potential for safe relocation of residents from one unit to another? What's our timeline to relocate or to evacuate? And what community resources are available to aid with evacuation? Do we have adequate resources available now? Will we have resources available if evacuation takes place later? And then will we have to relocate or will we need to do a partial or a complete evacuation? Your incident commander and your incident command staff need to have rapid awareness of situational awareness in order to make these decisions. The situation could be extremely dynamic, and though you may initially choose one strategy, you should always be planning ahead for further action. But the good news in all of this is that most non-notice evacuations do not affect your entire facility. You may have an urgent full evacuation more commonly than you would see no notice immediate evacuation. So you need to consider input from your technical experts. What do the weathermen say? What's your toxicology experts say for a chemical spill? Your internal command and structure experts, your facilities personnel, your medical director, your safety and security personnel. Have very good contact with your community emergency management personnel, your healthcare coalition, your public works people in your area, law enforcement, fire department, the people that will have up-to-date information and information flowing continually to them, and also your emergency medical services personnel. Make sure you have access to these technical experts in advance of an incident whenever possible. Pre-planning is worth everything. So we have looked at everything. We have been in contact with our experts, and it's decided that we need to move. We need to evacuate. At that point in time, you need to start notification and call in staff to assist with it. Make sure your emergency medical services is aware that you're going to be evacuating. The other transportation agencies you have contracts with, make sure they have been notified. The receiving facilities are notified, and your healthcare coalition for your area, for your region, is notified. Then internally, you need to notify the affected units that they're going to be moving. Facility staff or engineering staff at your facility need to be aware. The staff you're bringing in from the outside to assist you, your staff that's on call, and also the staff within your facility that are going to help move your residents or get them ready to evacuate need to be notified. Nutrition services need to be notified because we have to be able to maintain meals for these residents and your staff, and safety and security need to be notified. So what do your staff need to know? This is the most important concept probably of my whole webinar to understand. Reverse triage. Triage on units is when you're moving ambulatory residents in a group with an escort, they go first. Then your stable non-ambulatory residents go second, and then your least stable residents go third. That's to stage them. Once they're staged, then red go first, yellow go second, green go last. Triage during an evacuation reflects priority for EMS transport, not movement for staging. So the easiest to move go first off the unit, followed by those that are not as easy to move. But then when they are leaving to go for transport, then you go at normal priority. Red would be your most critical, yellow would be second, green would be last. Make sure your residents have a triage tag so everybody knows who they are and where they're going to in case they may have dementia and can't identify themselves. Make sure in an urgent evacuation you provide a list of the transportation needs to the command center. Tag their belongings. And print resident summaries if possible and time allows per instructions of incident command. What's their diagnosis, their allergies, their medications, their advanced directives in an emergency. If you have a little more time and it's an urgent move, add the resident summary, the medication administration record, and family contact information. Green residents are escorted to the staging area first, then yellow residents are moved, then the red residents are moved. Someone on that unit then needs to go through, make sure the unit is clear, and tag the doors with room clear. So anybody from emergency personnel coming in, if it would be a fire emergency, would know those rooms are clear and have already been checked. And the unit leader or charge nurse accounts for staff in the staging area and provides support for the residents until transported. When you're transporting them, consider the need for oxygen. Those water and food supplies for 3 days. Also anticipate that you may possibly have delays in transports or transfers if we have a severe weather hazard. And build that into your plan. So I have 3 tools I want to show you. This is a resident transfer checklist. This is a tool that I typed up. And it's just a graphic representation of reverse triage to evacuate your unit, and then usual triage once they're in the staging area to get them moved to another facility. Residents who do not require, in the green area, that require minimal assistance go off your unit first. But just remember, they can probably be moved by bus or another asset, and you don't need EMS to transfer those people. But when you evacuate off of your unit, green goes first because you can move them the quickest, then yellow, then red. But then once you have them staged in a location to then transfer them to another facility, the red goes first as they need maximum support to sustain life in an evacuation, then yellow, and then green would be moved last. So this is just something that I had developed that just to make it a little easier to understand that. This is a very good planning document. The link is here. This is a shelter-in-place planning document, and this was done by the American Healthcare Association. And there are many factors to be considered. This is a very good planning guide that takes you step by step through planning for evacuation or sheltering in place with examples, references, and comparisons to look to see what your center has already built into its existing program. I would highly recommend pulling up this website and reviewing it and reviewing it with your plan to see if you've covered all your bases. And then again, you have the 3 infection preventionists here at the authority to help you. And here is our contact information. And then I'm going to ask Jason and Pam if they would like to make any comments, because I know I ran a little later on this one than I normally do, and we're at time. So Jason or Pam, there is one question in the chat box, and since you are my resident experts, I'm going to let you take a look at it. It says, is this information from the proposed new regulations, or is this with prior PA regulation? And the information I have in here came from FEMA.
I would say it's in line with both. The new regulation is a little more stringent on your emergency operations plan, but from an evacuation standpoint, it pretty much in line with both of them. Joanne, you asked for a specific comment. I think probably the most important slide was the one you identified of the different players that are going to be a part of that incident. And while yes, it's certainly important to have that discussion with, my EMS chief, my fire chief of, what's the next step or the cascading events of this particular incident, but probably more importantly, it's having that discussion with them all together to ensure that we're making the best decision for the population that we're discussing. And in this case, your patients. Yes, there are subject matter experts in their particular field, but getting them all in the same room and having that true unified command to make the best decisions for your patient population would be important from my perspective.
Agreed. This is Pamela. I'll jump in really quick and piggyback on that comment. Not only the subject matter expertise at that and getting everyone on the same page at the time, but just to kind of reference some of the previous conversations we've had in this series is that sometimes this is why event notification can be so important really early in an incident. If you're in a situation where you're losing, say, air conditioning and it's the middle of July, and that's the concern that's potentially driving an issue like this, the sooner we know about that issue, the more we can do to prevent having to actually evacuate a facility. And so sometimes as coalition reps, your regional readiness coordinator, is able to come in and help facilitate some of those conversations in broker. If it's something remote, depending on what the incident is, we can provide a Zoom if you don't already have one up and running, to be able to help facilitate those conversations and kind of be a little bit Switzerland. I know something that's something Jason in particular is very good at, having served as a fire chief himself and understanding that perspective. So notifications early and often, and we'll do whatever we can to help troubleshoot and support. And there are many other subject matter experts out there that feel exactly the same way, doing the best thing for the patient. Thank you.
Thank you both. Christine, I'll now turn this back over to you.
Thank you, Joanne. This concludes our webinar for today. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Mixell at shmixell@pa.gov. This concludes our webinar.